Hey, so sorry for the delay, everyone. We had a slight technical glitch, but I think we are mostly online, about to be fully online. And for our folks who are streaming, you should be able to see the slides already. And welcome. My name is Gwen Driscoll. I am the Director of Communications here at the UCLA Center for Health Policy Research. It is my pleasure to welcome you once again to our 2016 Health Policy Seminar Series. And I want to extend a particular welcome to, we have a visiting delegation from Korea today, specifically 22 public health experts from the Korean Human Resources Development Institute for Health and Welfare. So welcome. Thanks for joining us. All right, so we're going to get started. I just want to make a brief announcement about next month's seminar. Please join us on November 29th. You'll have had your turkey, you'll have had a day to digest, so then you'll be back and ready for another one of our fascinating seminars. This is going to be about race and ethnicity trends in California. And it's a seminar that really is going to put in one place data on all the most significant trends affecting communities of color in California. Drawing upon comprehensive research conducted by the center's Ying Meng and Vanessa Lam for the Landscape of Opportunity, which is a report that was released just last week by the California Pan-Ethnic Health Network. This seminar will show how access to affordable housing, jobs, doctors, and quality health care, as well as safe neighborhoods and parks and much more. It varies depending on the color of your skin or your cultural community. Presented by Center Associate Director Ninez Ponce, a noted authority on health disparities, the seminar is a must for all interested in overcoming health inequity in California. So please join us again November 29th at noon. Okay. Okay, as for today's seminar, as always, we will be recording this, and in a day or two, it will be on our website at the address you see at the top of this slide. If you would like copies of today's presentation slides, please email me, Gwen Driscoll, at gdriscoll@ucla.edu. And of course, if you want to attend or hear about our future seminars, upcoming data releases, new research and publications, we're always publishing new and interesting things. Please sign up for our widely read e-newsletter, Health Policy News, and that is that bottom link there. All right, so without further ado, it is my pleasure to introduce today's speaker, Dr. Stephen Wallace. When the Affordable Care Act was passed in 2010, there were big questions about how the law would affect established systems of care. Specifically, how would the ACA affect community health centers, safety net organizations set up to provide care for medically underserved populations? Would they lose their uninsured patients to the private sector when they gained health insurance? If they kept many newly insured patients, would their new needs for additional care make it harder to serve the remaining uninsured? Would the clinic model remain viable in the post-Affordable Care Act world? Here to discuss the results of a nationwide study on this topic, released today and available on the center's website, is Dr. Stephen Wallace. Steve is the center's associate director and leads the center's research on health disparities. He's the chair of the Department of Community Health Sciences and a professor at the UCLA Fielding School of Public Health. He's also a leading scholar on immigrant health who has published cutting-edge work on the barriers that separate immigrant populations from affordable and quality health care. Last year, for example, he co-authored a nationwide study on the prevalence of state policies that support the health and well-being of undocumented immigrants. This report found that even California has room to improve on its policies that promote the health of this highly vulnerable yet economically essential group. Steve is also the co-author of Migration and Health, a benchmark biennial report that is a collaborative effort between the Center, the Mexican National Population Council, and the University of California, Berkeley. He's the lead author of today's study, along with co-authors that include center researchers and faculty associates, Maria Elena Young, Michael Rodriguez, Amy Bonilla, and Nadare Purat. Please welcome Dr. Stephen Wallace.
Thank you, Gwen, and welcome to everybody. Thank you for coming here today. We've got a couple initials, and so I just wanted to define when we talk about ACA, FQHCs, CHCs, etc., to define those before we get started. So the ACA is the Affordable Care Act, popularly known as Obamacare. So this was passed in 2010. And the discussion around the ACA has really been around expanding health insurance and reducing the uninsured population. But as I will talk briefly later, it had a major impact on community health centers as well. FQHCs are federally qualified health centers. Those are community health centers that provide primary care. They're a safety net provider. They serve primarily people below 200% of the poverty level, so it's a low-income population. And we often refer to them as CHCs, or community health centers. So there's some legalistic differences between the two, but through most of the presentation, I'll just talk about community health centers, and that's the group we're talking about. Okay, so let's move forward. Oops. So what did I pushed the wrong button. What should I do? So Gwen already acknowledged the co-authors of this, and I just want to repeat that. There we go. Projects at the center are always collaborative and want to acknowledge the important role of each of the members of the research team. And of course, none of this would not have happened was it not for the financial support of the Commonwealth Fund. We had done an earlier report for them looking specifically at undocumented immigrants and their access to care. And that actually led us to think about what was going to happen to this particularly vulnerable population as the Affordable Care Act, which explicitly excludes undocumented immigrants, rolls out and leaves community services as perhaps the last source of care for this group. So the Commonwealth Fund provided us with support for this project. So in today's presentation, I'm going to briefly, and since we got a late start, even briefer than planned, talk about community health centers and the Affordable Care Act funding and how that's created some policy changes that have impacted them, how community health centers and the uninsured are faring in the post-ACA era, or in the ACA era, some of the ongoing challenges and strategies that health centers are facing, and what we can do in terms of policies to improve their outcomes. So, very brief background. Community health centers in the United States got their start in the 1960s with federal funding, where they had a goal of bringing healthcare to underserved communities. There was a burst of policy activity in the mid-1960s. Medicare was established for older adults. Medicaid was established for low-income populations. And significant funding went into community health centers to establish locations within low-income underserved communities with the goal of bringing needed health services to those communities. When they were first founded, they were founded with an idea that they would serve the entire community, not just selected members of a community, and really had a focus on looking at both the health needs of individuals, but also the health needs of those communities. So they started primarily with federal funding that comprised the majority of their funding. As the number of people with Medicaid grew, the emphasis on community health centers seeking reimbursement from Medicaid, which is health insurance for low-income persons, was expanded in the 1970s. And so starting in the 1970s, community health centers became reliant on billing Medicaid for services for the insured patients who were covered by Medicaid. But they continued to serve as a safety net as well for those who had no insurance. Through the current era, community health centers have had widespread bipartisan support. So both Republicans and Democrats have supported the ongoing expansion and support of community health centers, in part because they are not free health centers, so everybody has to pay something when they go, and it provides a safety net for people who wouldn't have access to any other health care. When the Affordable Care Act passed in 2010, it promised that there would be a large expansion of Medicaid throughout the country. When it was first passed, it assumed that all states would expand Medicaid and cover low-income populations, importantly including both low-income adults as well as children, which many states have not covered in the past, as well as expanding private insurance for lower-income people through the exchanges. The debates over healthcare expansion, Obamacare, you can hear it in the current presidential discussions, has been the primary focus of the Affordable Care Act. But the Affordable Care Act also provided important new resources to community health centers. They provided a major increase in the core funding that each health center gets to help it compensate for patients who cannot afford to pay for care. It provided new funding opportunities to build new sites, to expand services, and to engage in enrollment and outreach activities that they had not before. And also provided new services, including dental, pharmacy, and other types of services. So the Affordable Care Act was actually a quite important policy, independent of its expansion of health insurance for community health centers. So what we wanted to know, given this, is what's happened to the people who community health centers serve after this major change in both funding as well as growth as a result of the Affordable Care Act. We had, you could call them hypotheses, you could call them concerns, but there were several scenarios that we thought were possible and that people in the community thought were possible as well, and Gwen mentioned those in her introduction. The first was that community health centers who serve large numbers of uninsured were hoping to see many of those uninsured patients gain insurance. What people didn't know is, would they take their new insurance and go elsewhere, which would leave community health centers hollowed out with only uninsured patients and declining revenues. The alternative hypothesis or concern was, what if all of these insured patients stayed in community health centers? They now have insurance to cover their unmet needs, and so they might bring a large amount of need to health centers that would crowd out the remaining uninsured. So the first two scenarios are both bad for the remaining uninsured. Either they're left in facilities that don't have the resources, or they're pushed to the side because the newly insured are taking all the resources. And then, of course, the third hypothesis, or this one I wouldn't call a concern, is that they're able to manage both, able to retain their insured patients, continue to serve the remaining uninsured, and continue their missions of serving as a safety net provider. So that's sort of the first bullet. The second was how the new mix of revenues is impacting services and populations. And then the third bullet really is what's coming next. How are community health centers positioned for the future? So we studied this through a number of methods. We interviewed 31 federally qualified health centers, community health centers, specifically looking at immigrant communities in 4 different states. And we picked immigrant communities or sites that served large numbers of immigrants because this is the group that is the most likely to be excluded from new health insurance options under the Affordable Care Act. Plus, in the both national and local political climate, immigrants are often targets, and the concern that they face in accessing public services might create additional barriers for them. So we picked the 3 largest states with the largest numbers of immigrants, so California, New York, and Texas. California and New York are both expansion states. They expanded their Medicaid programs, have been fairly aggressive in trying to enroll persons both in Medicaid as well as the exchange programs. Texas opted not to expand Medicaid. And then we picked Georgia, which has a smaller immigrant population, but has a very hostile policy environment to both the Affordable Care Act and immigration. So we figured those 4 states would provide an interesting contrast to look at the impact of policy as well as expansion. We interviewed the leadership at all 31 community health centers. We started with a survey that we sent out that they completed, and then we did telephone interviews with the 31. We collaborated with the state-level primary care associations, and then we went out and actually did site visits and were on the ground with 2 to 3 community health centers per site. We also then looked at the data from the HRSA Uniform Data System. This is data from all 1,200 clinic systems throughout the country. They have to report every year. And so for some of the context and trends, we looked at that data. So what did we find? Drum roll, please. So we found that community health centers continue to serve high rates of uninsured persons. So The uninsured have not been crowded out, but they're also seeing more insured persons. So they're doing both. They're seeing the uninsured and the insured. This shows you data from the 4 states where we did the interviews. You can see that the clinics we interviewed in gold were slightly more slightly more uninsured in most states. The blue is the statewide average for all clinics. But in Texas and Georgia, almost half of the patients, these are non-expansion states, remain uninsured. California and New York, it's lower, but still substantial. So nationally, when you look across all states, the number of uninsured continues to be high. The numbers of uninsured have gone down. But if you look at the total number of uninsured patients served in community health centers nationally, it accounts for about 1/3, or actually over 1/3 of all uninsured patients in the country. So the most recent data suggests that community health centers are serving between 1/3 and 1/5 of all the uninsured. That doesn't mean they also don't go elsewhere, but they're a major presence in the safety net of the remaining uninsured. And that's up substantially over the previous several years. So there's still many uninsured being served at community health centers. So those were the rates. These are the numbers. So I think what's interesting to note, this is just California, New York, is that there has been a secular trend. So the Affordable Care Act passed in 2010. It was not fully implemented in 2012, but the number of insured patients was already going up. And by 2014, with the implementation of the ACA, the number of insured patients went up fairly substantially in both of these expansion states, in large part due to expanded Medicaid. And particularly in California, the numbers of uninsured went down. So this is a glass half empty, glass half full issue. So in California, the number of uninsured went down dramatically, but we still have over 1 million uninsured people being served by community health centers every year in California. So that's not an insignificant number, even though the number is down from the levels in 2012. So what's your guess as to what's happening in non-expansion states? So in non-expansion states, we were surprised. So this is the same scale, so when you go back and forth, you can see these numbers are much lower. But interestingly enough, in both Texas and Georgia, the number of insured patients went up, but they didn't expand Medicaid. So when we went out there, we asked what was going on. And what they told us, I'll show you in a minute, is why. But the number of uninsured went up as well. So you can see from 12 to 14, it went down slightly in Texas, but it went up in Georgia. Basically, there's no significant change in the number of uninsured in the non-expansion states, even as the number of insured went up. So this is a bit of a dilemma. How do you get more insured patients? So a community health center director in California, one of the expansion states, said, well, there's a tremendous amount of publicity and buzz around the rollout of the ACA. We heard that in both Texas and Georgia, as well as California and New York. So what they noted was that with the new money from the Affordable Care Act, they were doing a lot of outreach and enrollment. Even in Texas and Georgia, they were doing outreach and enrollment for exchange patients. Now, in neither of those states are they seeing very many exchange patients, but they were out in the community, and they actually found a lot of people who are eligible for Medicaid who are not enrolled. So they were enrolling already eligible people in Medicaid and bringing them into their system. And then simply by being out in the community a lot more through their enrollment and outreach activities, people in the communities with Medicaid also learned about them. So even though those states did not see an expansion in the numbers of eligibles for Medicaid, they actually did see an increase in the numbers of people who were enrolled in Medicaid and using their services. What's interesting is that in none of the sites was the exchange policies a major contributor to their enrolled populations. And in fact, in a number of sites, they complained about the exchange policies because they had different reporting requirements, they had different allowed and unallowed procedures, and they were used to how you had to bill for Medicaid, but billing private insurance was not a strength of theirs. And so that whole process was problematic as well. So what about immigrants? As I noted earlier, undocumented immigrants are explicitly excluded from the Affordable Care Act provisions, and many legal immigrants who are recent immigrants have also been excluded from federal funding for health insurance. So what we saw, once again, the blue is statewide average and the gold are the clinics that we interviewed, is that in most states, clinics are serving a disproportionate share of immigrants in their populations. So the caveat here with these numbers, this is the only data that the clinics report is the percent of the population best served in a language other than English. So it's a limited English population. There are people who have been here a number of years whose English abilities are quite good, but we looked at some census data and we looked at other data, and this is a fair approximation. It's a little bit low. And then the triangle is statewide from census data, what proportion of the low-income population, which is what community health centers pretty much are limited to serving, is immigrant. And you can see in California, about a third of the low-income population is immigrant. And at all clinics around the state, 43% of their patients are best served in another language. So you could probably guess that about half of their patients are immigrants. So that really reinforces the analysis that community health centers are reaching out to hard-to-reach populations, including immigrant populations. So there was a, oops. Here we go. One of the clinic directors in New York said there's a general perception with elected officials and foundations that everybody has insurance now, but 17% of our patients, which is low nationally, are still uninsured and undocumented. So they're continuing to fulfill their mission of serving the hardest to reach. And immigrants bring a whole set of extra barriers with them. Not only are they explicitly barred from Affordable Care Act products if they're undocumented, I mentioned even recent immigrants are often excluded from Medicaid. And then on top of that, the local politics, which we looked into, also serves as a bar for immigrants seeking healthcare services, as well as the national climate. In Georgia, we interviewed a clinic which had about 25% of its population they estimated was undocumented, or in families with undocumented persons. And the local police department would set up license checks. They would stop cars on the only road that comes to that clinic regularly and ask to see people's licenses. If you're undocumented in Texas, you don't have a driver's license. So if you're driving without a license, you're then subject to arrest. If you get arrested, they turn you over to the Immigration Service and you get deported. And they had several examples of clients of theirs that had happened to. So they noted that a number of their patients now were taking taxis to come into the clinic. So remember, this is a population working for minimum wage, often on irregular jobs. And they're taking taxis in because the taxi cab drivers have driver's licenses. And the police check is to confirm that you have a driver's license. So you might say, well, Georgia, we know they're against the Affordable Care Act. We know they're very anti-immigrant. California and New York, we're different, right? Well, a clinic director in California told us about the Immigration Naturalization Service parking outside their clinic, not actually stopping people per se, but intimidating them by parking outside the front door and leaving their car there for the better part of a day because they knew that in that particular clinic, a large number of undocumented immigrants were users. In New York, we talked to a clinic that similarly had Immigration Naturalization Service who would park outside, and they described helping some of their clients leave through the back door so they wouldn't feel intimidated as they were seeking care. So even in New York and California, where we often think of ourselves as very inclusive, there were plenty of examples of both police and Immigration Service explicitly targeting clinic users because they might not have the proper documentation. So that presents an additional barrier to serving those populations. So in some, community health centers are serving the remaining uninsured, as well as serving the remaining and newly insured. And in all of the interviews that we did, it was clear that they continue to be very mission-driven to serve low-income and disadvantaged populations, and are really key safety net providers for the underserved. So some of the ongoing challenges and strategies include 4 areas. First, which I mentioned, was the Affordable Care Act provided extra funding for clinics on a short-term basis. It was originally scheduled to be until 2015. It was to help clinics get ready for the new influx of insured patients. And in 2015, it was extended to 2017. So they talk about this as a fiscal cliff because community health centers could lose half or more of their federal core funding if this provision expires. None of the sites that we talked to were really ready for this because there was no place to put that to come up with money to backfill that if it disappeared, and all of them were dependent on it for providing services both to the uninsured populations that they continue to serve, as well as some of the expanded services that they offer that are not reimbursed. So the short-term funding provided needed support, but is a future challenge. So as Georgia Community Health Center Director noted, we provide care regardless of someone's ability to pay, and the federal subsidies help to underwrite our costs. Eliminating federal funding would impact us, especially our core grant, as far as being able to afford the appropriate and qualified staff to provide the quality of services that we want to provide and that we believe the community deserves. So this phrase also sort of reinforces that mission-driven. The community deserves good quality care, and to provide that costs money, and if the federal funding gets substantially cut, that'll impair our ability to provide that. Community health centers, we found, face infrastructure and financial barriers. So if you've done work with small community organizations in any sector, you'll know that this is not a shocking finding. But what's different with the Affordable Care Act is that this landscape is changing under them. And so the infrastructure and financial problems or challenges that they're facing are different. So many of the clinics have expanded. There was money for both construction and new services in the early 2010s. And even with this expansion, they find that they're operating at capacity. And they're operating at capacity, and it's not clear how much further they could build out in many cases. Many of them could serve more people, but they have constraints on space. They literally don't have enough exam rooms to see people. Others have space, but don't have the professional staff that they need to serve the patients. And in most of them, they actually face administrative challenges. So it's kind of interesting because when you think of a clinic, you think of doctors and nurses and translators and maybe community outreach people. What you don't really think about are the IT people and the people who write the grants and file the HRSA reports that we put the data off of. And in many centers that we talked to, that was part of the gating factor also, is they didn't actually have the administrative capacity to serve more people, to even, in some cases, for some of the smaller clinics, write the grants. If they were writing a grant to get a new building, they were not doing something else that was essential to keep the clinic going. So part of the infrastructure and financial barriers is being able to afford sufficient administrative staff, talk about that in a minute, but also to be more proactive in seeking opportunities, which is difficult in an uncertain environment. They don't know if they'll have continued core funding at the end of next year or not. They don't know what the Medicaid rules are going to be in 2 or 3 years. So actually planning for the future becomes difficult, and as a result, they often end up being reactive to opportunities versus proactive. In New York, Community Health Center Director said, my goal was to create services for a number of years. I thought the finances would follow automatically, right? So you offer dental care, you get reimbursement, right? Well, but it doesn't necessarily catch up with you. He said we need to refocus on financial planning and contingency and collections, and electronic medical records and all those kinds of basic things. So that infrastructure support is critical as they expand and change the types of patients they're serving. So part of the changes is the service mix and payer mix. So what all of the clinics are seeing is a growth in adult primary care. So community health centers, when they were first established, really focused on children and mothers. And now they're expanding to try to serve entire populations, but the sites complain that a lot of the adult primary care is not well reimbursed, and that there's not a lot of funding to expand services in those areas. They also need to balance, as they're growing, what is reimbursed with what's needed. So one example that was given in some sites is the high need for dental care. Some states cover that with Medicaid, other states don't. So in some states that actually becomes a desirable revenue source. In other states it becomes a further drain on their core funding because of the high proportions of people who need it and can't afford it. A lot of clinics are moving into pharmacy. Plus there's many services that aren't reimbursed at all, such as case management. Outreach and enrollment is funded under some of this ACA money, but that might then go away. And interpretation services are all areas where they have to carefully balance what needs to be provided with what they can generate funding for. Recruitment and retention came up frequently in talking with these community health center directors. One in California said, if you want to do it right, you have to have the proper staffing for it. So simply building clinics doesn't provide the care. You need the people that can do the hands-on work. And what a lot of these sites mentioned as mission-driven organizations, they have to find not just a competent nurse practitioner, but a competent nurse practitioner who fits with their mission to serve difficult-to-reach, sometimes complex populations, and that not everyone fits. So it's not simply a matter of going out and picking up the first available practitioner, but it's a matter of finding one who fits with the mission of the organization. Many of the sites are providing non-financial incentives to try to keep their own employees. A lot of them talked about, say, for example, for physicians, Kaiser being able to outbid them, that there would be no way that they could match a Kaiser salary, including signing bonuses of $100,000 and things like that. So they tried to provide other types of ways of attaching the people to their organization. One of the biggest ones is their mission-driven focus, so that people who really want to serve the underserved, who really have a caring approach, want to be there. They involve direct care staff more in the operation of the clinic than you might in a large organization or a for-profit organization. Getting them engaged in helping to decide priorities for the clinics, input into how clinics operate. In other words, giving them a stake in the operations so that they see themselves, they identify with that clinic as well. And a number of sites talked about professional development and really wanting to grow their own. So that was a little bit of a challenge for them because they would take, say, a receptionist and get them certified as a translator. And then as they were ready to start using them as a translator, the local hospital would hire them. So it's a mixture of making sure people know they have a career and a career ladder within the organization. And a number of the clinics we talked to introduced us on the site visits to people where that had been successful and they had stayed and were happy. So workforce recruitment and retention continues to be a major challenge. So what do we do to help stabilize and foster community health centers for the next decade? So, you know, it's an old story, but money always helps. The biggest part that everybody talked about was the core grants. That if the core grants get cut back and the latest budget, which still hasn't passed, it's a complicated formula, but there's sort of an ongoing and a one-time boost in the core grants. And they've shifted some of the money out of the ongoing into the one-time. And so if that one-time funding expires, then they'll be facing an even larger cut than they have in the past. So a permanent boost in that federal core grant would really provide them with a stability of funding to know that year after year they'd be able to count on those funds to subsidize the uninsured and to subsidize services that were either uncompensated or poorly compensated. And if they don't get that, then we'll be back here in 2 years and talking about what's happened to the remaining uninsured, probably in a less positive manner. Another solution for the money is to insure the remaining uninsured. So in Texas and Georgia, the consensus among all of the respondents, no surprise, is that some sort of Medicaid expansion would be the best solution for them to be able to provide the services to the populations in their areas. There are a variety of models for this in states that did not want to do straight Medicaid expansion. And they were ecumenical as to how it expanded. Simply, if more of their uninsured patients had insurance, they would be able to do better. In addition, even in expansion states such as California and New York, as you noted, there were still large numbers of uninsured. And reaching those nowadays requires extra efforts above and beyond the current Medicaid expansions. California and New York both have Cover All Kids expansions that are rolling out, and that will help for the younger populations. And we need to expand that to all parents and all adults as well. So if all persons had insurance, that would make a huge difference for these sites. There are local initiatives in a number of areas, My Health LA being an example that provides some funding for the uninsured, but in talking with clinics, the amount of funding that's provided is relatively modest and doesn't fully cover the cost of providing services to those individuals. So as far as the clinics are concerned, those individuals are still fairly uninsured. They're not totally uncovered, but they are still a net cost to the system as when they're being provided with services. So providing insurance would be the best way of covering them. Workforce flexibility and availability. So we're not going to train up thousands of new doctors in the next 2 or 3 years to take positions in primary care practice and community health centers. So there are a number of areas where we can fill some of those needs. Scope of practice laws is one area. And this is very state specific because each state has its own scope of practice laws. In Georgia, they described a clause that made it difficult for nurse practitioners to see patients when there was not a supervising physician immediately available. So in rural sites in particular, this could provide, they give examples of numbers of days where they actually had to turn patients away because the supervising physician wasn't available, even though the nurse practitioner in many other states would be fully capable of providing the primary care that was needed. So expanding those types of scope of practice laws would be a benefit. Expanding what is reimbursed, for example, interpretation. Some of these outreach and enrollment are grant funded, but making a broader coverage for what is paid for would help in terms of flexibility. And then a fairly technical issue that came up that everybody agreed would be helpful to some extent is expand the Federal Claims Torts Act. Who knows what that is? 1 or 2 people? So under federal law, if you are a full-time employee of a community health center, a medical practitioner, you are basically exempt from being sued for malpractice. So you're covered under this federal exemption. But you have to be employed by the community health center. So a number of these community health centers have community physicians who are willing to come in and volunteer a couple days a month, but they have to pay for the malpractice insurance for those community physicians to come in and volunteer. So a number of sites said, if we could expand that, it would be relatively easy. We could make it specific to community health centers or federally qualified health centers. That would allow them to use more volunteer labor in their clinic services. So that's another example of how you could increase the resources at community health centers, engage them more in the community, and not cost any additional budget. Finally, in the area of financing, community health centers need to prepare to move away from fee-for-service or cost-based reimbursement. So in some states, they continue to have just a straight fee-for-service, sort of the old-style reimbursement. Other states, there's capitation, but it has a complicated wraparound system. So basically, they're still paid on a cost-based system. And the effort now nationally is to move away from cost-based reimbursement to what they call value-based reimbursement, or more of a capitation style. And to do that, they're going to need to come up to speed on using their patient data. Many of them continue to struggle with data systems. I have some other projects where we're actually asking clinics to generate data for us, relatively simple data that we know is in their systems, that they know is in their systems that they agreed to give us, and providing that simple data becomes a major challenge. So if they have to do financial forecasting, if they have to report additional data beyond what they're reporting now to health insurance companies, it would be a major challenge for them. They also have to increase the capacity on financial modeling, on strategic planning, and a number of other areas so that they would be ready for the eventual shift to a value-based reimbursement system. Some of the directors were afraid of moving to value-based reimbursement. Others were hopeful, and as with everything, they said the devil's in the details, that they worry that any formula change around reimbursement will not take into account the fact that their patients tend to be sicker, more complex, and have additional needs, whether it's transportation, translation, case management, and so forth, that somebody in the private sector may not need. So they're concerned. The ones who are hopeful, who are like ready for this to say, you know, let's roll it out, also want to make sure that the systems don't take a commercial model and impose it on them, because they don't have commercial patients. They have patients in hard to reach, low income, uninsured communities. So helping them get ready for that would make a big difference in the future. So Georgia Community Health Center Director sort of summed it up by saying, all the ups and downs and not knowing whether or not you're going to be funded, it's been hard to plan. It's not been an even playing field. Half of the volatility comes from our federal funding side. That's that sort of core money, not our everyday patient population, because that hasn't changed. So trying to figure out the future, trying to plan for what's coming has been a challenge. So I've just sort of given you the highlights. More details are available in a policy brief that was released today, which the title is sort of the summary of my talk. Community health centers play a critical role in caring for the remaining uninsured in the Affordable Care Act era. And we do go through, we present some of the data that I've shown you here today, and do conclude that community health centers are actually growing in importance. So they're not becoming more marginalized, but they're actually growing in importance as safety net providers for underserved communities, especially communities with large numbers of immigrants and large numbers of undocumented immigrants who face multiple barriers to receiving the care that they need. Their future, the future of the community health system, the future of the federally qualified healthcare network depends on continued core funding, flexible workforces, and continued bipartisan support of their mission to reach those low-income communities and promote the health of all populations in the country. Thank you. So there's several members of the study team here too, so if there are questions that I can't answer, I will defer to them.
So we're going to take one from the online folks, one from the live folks, and so on and so forth. If we don't get to all the questions, please email me. My email's right up there on the screen, and I'll be sure to get an answer.
So can they hear you, Gwen, on the?
I just typed that message to her.
Got it. Okay.
What are the prospects for the core funding?
So what are the prospects for the core funding is the question. That's a good question. In 2005, the extension of core funding was part of a grand bargain to not throw the government into default. So there's a significant number of congresspeople and senators who are very supportive of ongoing core funding. They may not be the majority, and so as part of a package to say, okay, we'll agree to these cuts in this part of the budget if you agree to continued funding in that part of the budget. That's what happened in 15. So I know advocates are working on it, but they don't even have this year's budget, let alone next year's budget yet. So it's hard to say it's premature, but they're starting the move, and once this year's budget gets passed, after the election at some point, then the big press will be to make sure that funding continues. And not to be partisan, but it probably depends on who ends up in the White House.
So online question, I'm actually going to ask you two because one I think you can answer pretty
Okay.
What cities were encompassed, or at least major cities, by the survey?
Okay, so good question. So we picked 2 areas in each state.
If you could repeat the question.
Oh, so the question was basically of the interviews we did, what cities, what areas did they represent? So we picked the largest city in each state. So that was Los Angeles, Houston, New York City, and Atlanta. And then we picked a second area that had a high concentration of immigrants as well. We were thinking a second city, but in many cases, a less urbanized area made more sense. So in California, we went to Fresno, which includes both the city, but also the surrounding farm area. In Texas, we went to South Texas, which is very rural, very different sort of composition. In Georgia, we went to South and East Georgia, which once again, very rural. So the issues there, so if they've got, issues in their community health center, it's because they have one doctor and one nurse practitioner, right? So an urban health center might have several of each, and they've got one hospital to work with versus multiple hospitals, and there's no county hospital, right? So the whole set of issues in those rural areas are even more complicated than urban areas. And then in New York, we picked, I was gonna say Long Island, it's Hudson Valley, which once again is a more rural area, but also has a large immigrant population. And then the statistics are national. So they're like, when I say the state of California, it's all clinics in the state of California.
So actually, I'm going to go back to the room because that was more than I thought it would be.
Okay.
We have one in the room. Jerry.
Steve, so at the beginning of your talk, you mentioned that there were sort of 2 concerns. One is that with the expansion of insurance, that people who previously went to FQHCs would go elsewhere and leave the uninsured to be treated. That doesn't appear to have happened. So the other concern, though, was that now the newly insured would, in a sense, crowd out the remaining uninsured. And I'm not sure that whether or not you can address that or not. And in your interviews, was there any indication of what is actually going on? Because it looks like what's happened is they're treating more patients. They've expanded their patient base. And in some cases, at least in California, the number of uninsured has been somewhat reduced. But how are the uninsured faring now in this post-ACA world?
So the question was, I posed 2 possible hypotheses. One is that the newly insured would leave the community health center system and go to private providers. The second one is if they stayed, if they didn't leave, they might crowd out. They might soak up all the services and make it difficult for the remaining uninsured. And so the question was, what did we actually find specifically on that second part? Because it's obvious that the numbers of insured patients is going up. So they are keeping a large number of patients who used to go there who were uninsured and now have insurance. And as we suspected at the sites, they did talk about those newly uninsured as being heavy users, right? So if you only go in when you're really sick because you don't have insurance, and now you have insurance and you go in and you've got diabetes and hypertension and asthma, and you're beginning to get some arthritis, the amount of just primary care you need to get all of those conditions managed becomes very extensive. So a lot of sites, and that was part of their capacity issue. So I mentioned they're operating at capacity. For some of them, it was working through this large unmet need that now more patients have the resources to meet. But so qualitatively, we didn't detect sites, and we asked them, and you would probably have to look at maybe more detailed clinic data to look at numbers of visits, not just numbers of patients, and referral patterns and so forth. But they did talk about some of the new resources coming in from the ACA, allowing them to continue to serve the uninsured patients who might have been crowded out. Some of the costs that they'd had to incur around outreach, some of the administrative costs, some of the other types of things they've been getting grant funding for. So that allowed those staff to do more of the clinical and work with the underserved. So I think that the crowd out question still remains, but we didn't see any obvious indicators of it. And that's part of that mission-driven piece too, right? So they would they would like do whatever they needed to, I think, to hold on to that remaining uninsured.
So we have an online question, why was there a difference in the percent uninsured between all the FQHCs and those interviewed for the study?
Right, so when our selection, so the question is why for all FQHCs in the state was the proportion uninsured different than in the FQHCs that we interviewed? So we basically did a purposive sample. We were looking for FQHCs that had a lot of immigrant patients, so not a cross-section of FQHCs, and in those two specific areas. So the statewide data is just that. It's in California, it's hundreds of FQHCs, and we interviewed 8. So the fact that they don't exactly mirror the state is actually what we wanted. We wanted to find the clinics that were likely to have the most challenges. So the higher proportions of uninsured, the higher proportions of immigrant patients. And so if they can manage, or whatever challenges they're facing, would be instructive for the rest of the system.
Question in the room? We have a lot of online questions.
Okay.
Steve, so one of the things I understand from the ACA is there's the change in the Medicaid payment system, at least from the feds to the states, and then there's a question about whether or not with the PPS, the states are actually passing that on or changing the way that they reimburse these health centers. Did that differ, or did you get into that, and whether that differs across the states that you were using here, and any at least initial impressions about impact?
So in Georgia, they're still just doing fee-for-service like they were doing 20 years ago. So that's the simple answer. In California and some of the other states, they do this really arcane wraparound system. So they get a PPS, they get a fixed payment per patient, but then they track the numbers of visits, which is the numbers of days that they provide services. So you can make 5 visits in a day, it just counts as a 1 day of service. And then at the end of the year, through the cost-based system, they say, well, this is what, if we'd been paid fee-for-service, it would have cost us up here. And this is what we got reimbursed through the PPS. So then that gap, they then apply for, and then the state a year or 2 later gives them that gap. So right now, actually, they're not at risk. What they're at risk for is carrying sort of a deficit of if they're overspending, but they'll get it back eventually. And so for some, it was a cash flow issue. It's a complicated system. Yes.
Okay, so we have a lot of questions
Okay.
about whether the study looked at access to affordable specialty care.
So we did ask about, so the question was whether or not we looked at access to affordable specialty care. And that is sort of the #1 challenge of community health centers going back to the 1960s. So they provide primary care. A lot of them are adding services, say OBGYN. Some of them are adding some more what would be considered specialized care. But for the majority, if you need an expensive lab test, if you need a cardiology consult, you're going outside their system. In many states, if you're uninsured, that means you go to the county hospital or to a doctor that's agreed to take a couple people free of charge. And so in Georgia, they talked a lot about the time they spent developing relationships with community physicians to take 2 or 3 referrals for free per year. So you can imagine, like, if you've got thousands of patients, 5,000-10,000 patients, and you need 100 cardiac referrals per year, and each cardiologist is willing to take 3 to 5 a year. Just the numbers, you've got several people doing nothing but going, knocking on doors, networking at meetings, getting names, and then making sure you don't burn them out, right? So if they say, we'll take 3 to 5, you send them 15, they're going to say, no, I can't do this anymore. So that's another part of that, needing to increase access to insurance, because then when they go to the specialist would get some payment. There'd be more of an incentive to take that person on. So that is one of the big challenges, even if you've got a usual source of care at a community health center.
Do you want to talk about how there'll be a phase 2 to this study? Will you be looking at that?
So I was asked about a phase 2 to the study. So what we have done is we've looked at 4 different models for improving access to care within the existing system, one from each site, and sort of strategies that community health centers can use Some of it's around specialty care, some of it's around just general access to health care. And so we'll be doing a series of profiles of promising practices, maybe not best practices, but promising practices across the 4 states, and how they can mix the payer incentives they have and try to get the care for the patients that they need. So stay tuned. That'll be maybe a February center seminar.
And here's where you say you should stay subscribed to the center newsletter.
And that's why you should stay subscribed to the center newsletter, so that you can hear when the case studies are released. We're also doing a quantitative analysis of the uniform data system data to look at the impact of immigration and patient characteristics on the uninsured at the clinic level nationally. So lots more coming from this project. Stay tuned through your newsletter.
Yeah. We are really past time. I want to emphasize that if anyone has questions that we're not answering, you can email me, you can email Steve. His email is up there. And for the online folks, I've already told them that they can email me and we'll try and address any unanswered questions. But thank you very much, Steve.
Thank you.